Right, good morning still. It is September 21st, 2021, 9/21/21. I'm Dr. Ara Deukmedjian, CEO and founder of Deuk Spine Institute, here with you. We are broadcasting live spine surgery as we do every week, every surgery, so that you, the viewer, can participate with us during the surgery. You can see what really happens in the operating room and be part of the experience with us. You can ask questions, you can see what happens in real time. Now our patient, this surgery, has chronic back pain, and the pain goes from his back down into both legs. Now, take a look at the x-ray. Can you show the x-ray?
Yes, it's showing the x-ray.
All right, so you can see there's very bad scoliosis. This is called degenerative scoliosis as opposed to idiopathic scoliosis. Idiopathic scoliosis happens in kids. They don't have degenerative changes to the discs and facet joints, whereas adult degenerative scoliosis occurs in adults, and it's secondary to collapsing discs and subluxing sliding facet joints. Now, we are not fixing this patient's scoliosis. That would require fusion with screws and rods and osteotomies. Instead, we're just going to treat his back pain. I expect to be able to get rid of the back pain with the surgery, okay? And the surgery we're doing is a Deuk laser disc repair. Our patient is awake. Are you comfortable? All right. It looks like he's planing a little bit with this side down, my side up, so when we do the orbit, just keep that in mind, okay? All right, we're going to get started. You're going to be awake for the first 20 minutes. Then we're going to put you to sleep. We'll do the surgery after that, okay? But I need your help in the beginning. You're going to feel a little poke. That's just the numbing medicine going in, okay? You what? Uh-huh. Yeah, so down the right leg primarily, I understand. Yep. I'm giving you numbing medicine. You feel that? All right. I apologize. I know it's a bit uncomfortable. We're going to go on both sides for that numbing medicine. And that should make you feel better a little bit later on, okay? If you feel pain, you just say, ouch. And that'll be my cue to give you more numbing medicine. So we're on the left side to begin with. I'm going to start with accessing L3-4. So L3-4 is left, correct?
Yes, sir. Agree.
So on this side, we're going to access L3-4. Shot? All right, let's go lateral. I'll need to stand here. Yeah, you stand here. Keep your hands over here. Yeah. No. Nope, I want to see the patient. So our first surgery is ready to go home, but I'm not ready for him to go home. That's fine, but I want to check on him before he goes home. All right, we need to get this side view cleaned up. So we're fixing 3 discs, L3-4, 4-5, 5-1. At 3-4, we're going on the left side. At 4-5 and 5-1, we're going on the right side. This is the patient's left side because he's laying on his belly. I need you to show me the sacrum. I need you to get 3-4 lined up. So Jordan is helping me as our x-ray tech. Shot. All right, so 5, 4, 3, 3, 4. You got an orbital issue. You can see a double, that's too much movement. You can see a double shadow in the back of L3. That's, I think, better. All right, L3, yes, that's fine. Are you comfy, sir? You just lay still and let me know if it hurts, okay? Don't talk to me otherwise. You have pain on your left side of your back. Yeah, all right. Okay, good. Shot. All right, good. So, looking good so far. Everyone agrees 3-4?
Agree, sir.
We need to get around it. Shot. So I'm going through the foramen into the L3-4 disc. Shot. I feel like I'm passing through. Normally, everything feels good. Again, we are not correcting scoliosis. We are quite literally only going to be treating the disc herniation here. Shot? All right. Now clearly, I think we still have an orbital issue. If you can help me with that, I'd greatly appreciate it. Shot? Let's go lateral. I mean AP. Let's see where we are. So I think I'm bumping up against the top posterior margin of the L4 top left end plate. I just want to make sure. Yeah, it looks good. Back to a lateral. Pretty collapsed on this side. You could see that at L3-4. He's collapsed on this side. And that's probably why, contributing to why the nerve is getting pinched on this side, whereas the foramen's open on the other side, it's pinched down on this side. Are you comfy? Yeah. All right. Just bear with me. Shot. It's a little better, but still not enough. Shot. 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 That's a little better. Shot. Yeah, definitely better. Are you comfy? Just relax your back. That'll help me. Everything's going well. So he's pretty collapsed at 3-4. You can see the vacuum disc phenomena, the white line there at 3-4. Yeah, so we're right there. I'm not quite where I want to be, but it's good enough for now. All right, now we're going to focus on 4-5. Are you comfy? Yeah. Good. Let's have some more numbing medicine. So we're going to go to the right side to treat L4-5 and L5-S1. And this is where he has his leg symptoms, primarily on the right side. And on his MRI, I can see that the herniation on the right side is closing off the foramen, the neural foramen. So, all right, let's focus on 5-1, since that's going to be the harder one to get. Blood pressure good? See if we can get that down a little bit. All right, that's pretty good on 5-1. Let's get the pedicles lined up a little better. So before you navigate with your needle, you have to make sure that your navigational information is reliable. And the navigational information we use for these surgeries is an X-ray machine. It gives us imaging of the spine itself. Shot. So that's what I'm looking at right now, is these spinal images that we have with an X-ray machine. And it's not just any X-ray machine. This is the top X-ray machine. It's Siemens X-ray machine. Siemens, a German company. Shot. And they make probably the best X-rays in the world. Shot. You're doing great. Just lay still. What's he saying?
It's painful. Where does it hurt?
Shot.
He says it's painful in his back.
Yeah. All right, let me see if I can give you a little more numbing medicine to make it better.
Numbing medicine, okay? It's a lot of pressure.
So the patient has to be awake for the beginning to help me navigate. I use the X-ray images, but I also use information from the patient himself to get down to the spine to where I need to be. Shot. 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 Yep. So we're encountering his facet joints. Shot. Shot. Let's go AP. And just for those of you who don't really understand a lot about the spine anatomy, this is not an easy surgery to do because of the bones are out of alignment, out of normal alignment. So I'm trying to get into a tiny little space around the bones, and that space is compromised because of bone spurs and arthritis and other things like that. And so navigating to the disc, though it may look simple, it's really not simple at all. It's actually very difficult. I try to make it, I try to do it properly, but sometimes you encounter challenges. Sean? Let's get an AP. I think we're where we need to be. I just want to make sure. So if you've ever seen those movies with ships in rough seas, navigating rocky coastlines, like through rocks and things like that, that's kind of what this is like. I have to navigate this needle past, you know, all these juttings of these giant rocks and outcroppings and coral reefs so that the ship doesn't crash. And there's a very narrow passageway that I have to go through, and sometimes the passageway doesn't let you. That's very rare, but it does happen. But I can feel literally his bony spine and arthritis grabbing this needle as I go in. I can feel it grabbing it and like all around it, and there's literally a millimeter of space to get through. So the passageway is a millimeter wide, and I'm fitting a 1.5 millimeter needle into a millimeter space. So it takes a lot of jockeying and making sure your navigational information, which is the x-ray images and the patient being awake helping me, kind of guiding me. I use both pieces of information, both maps. All right, so we need to clean up 4-5. So the pedicle of 4 is looking better. I guess that's pretty good right there. Why don't we just use that, okay? And again, it's right side 4-5-5-1. Everybody in agreement, right? Knife. So I have navigated at 5-1. And by the way, endoscopic surgery of the spine is not done really at 5-1 because it's so difficult to do. And I'm the only surgeon basically in the world that does it regularly. Now, the surgeons that do endoscopic spine surgery around the world, like in China and Germany and Korea, to do L5-S1, they go interlaminar. They basically go through the middle here, and they have to remove bone and ligaments to get there. But to do it transforaminal, which is what I do, is the hardest. And most surgeons don't even try doing it transforaminal because they're not capable of doing it transforaminal. They don't have the skill to do it or the tools to do it. And we do it all the time because it's better for the patient if you can do transforaminal. You don't want to go interlaminar. Interlaminar means you're removing the lamina and you're removing ligaments that are supposed to be there. Interlaminar, or translaminar is the other name for it, is the approach that most spine surgeons, like 99.9% of spine surgeons, use. But it's destructive to the spine because you have to take out bones and ligaments. So to go transforaminal, you're not removing any bone or ligament. It's much safer and it's much better for the patient, but it's much harder for the surgeon. Sean? But I still do it anyway because I can, and it's the right thing to do for people. So I've just honed my skills rather than run away and give up and not try. Sean? I've learned to navigate these straits. So why do I talk about that? It's important to understand that the surgery surgeons offer you is typically biased tremendously by what they feel comfortable doing. And the easier the surgery is to do, the more likely they're going to recommend it. But, you know, my father used to always tell me the best things in life are usually the hardest things to achieve. So it's true in spine surgery. If you want the best spine surgery, it's not easy. It's hard to achieve that. It takes a lot of work, a lot of studying of the technique and modifying the technique and assessing as you're going along. So if you want to do the best for the patient, it's going to be the hardest usually to do, but you can't give up. You have to be able to go see it through. All right, AP. So we've accessed 5-1. We've gotten close at 3-4. Close enough for me to get a guide wire down there, and when the patient's asleep, I'll be able to access 3-4 with the dilator. And 4-5, we're getting close. I'm hoping we're in at 5-1. Let's see what we got there. All right. And there's just a lot of scoliosis, so it makes things look weird. All right, so 4-5. Are you comfy? Yeah. Sean? Where do you feel that, Sean?
Where do you feel it? You're doing fine.
No, you don't. Yeah, your nose is probably a little stuffy. That's normal. All right, don't worry about that.
Okay, doctor asked you a question now.
Oh, he's fine. I'm where I need to be. I want to see it shot. I want to see if I can get into that 3-4 now. He's a little distracted. Let's see if we can. Maybe he's more relaxed and we can access it better. I just know I can see the tip, and it's rubbing up against the end plate of 3. So, yeah, there's too much arthritis. Oh, there we go. Maybe there. Yeah, a little bit. I think we might have gotten it. Yeah, I think we got it. Get a shot. Yep. Hey, they say it's better to be lucky than good, right? So, I think we're in. Still just, I can feel. So what's happening here is normally you got these vertebrae, right? These bones, like L3 and L4, and there's a disc, a cushion between them. But when people get a tear in the back of the disc and they don't get it repaired with the Deuk laser disc repair, over time it collapses the bones down on each other, and you basically just get complete bone on bone. It doesn't mean that that needs to be jacked open and fused. What it means is we still need to go in there and do the Deuk laser disc repair, but getting a needle in there is hard. Where's the needle? We don't have any more? So put your hands here together. Luis is going to demonstrate the vertebrae. This is normal, right? I'm coming into the disc through the tear, but when you have somebody who's totally collapsed, you're like this, and I can actually feel the bones crushing on the needle, squeezing it, so it's really hard to get in. So we're talking about sub-millimeter space, but we're in. Okay, we're in. So I'm very happy with the progress. Are you comfy? All right, so let's put the lights. Now, we're going to do the discograms as we always do, where we test the discs. And we got a 3-4, a 4-5, and a 5-1, okay? Are you comfy then? Have you watched me do any of these surgeries, sir? How bad is that on a scale of 1 to 10? 10? Was that where you typically get back pain? Good job. We found one of your painful discs and we're going to fix it. That was the L3-4. You'll see it on the video when you watch this tomorrow or tonight. A lot of my patients, that was L3-4 we tested. All right, so definitely a painful disc. And you can see the tear with, take another picture. So take a look at the tear. Show them the tear with an arrow. Jordan's going to bring the fluoro arrow over and show you where the tear is, right there. So that back part of the disc there where the needle goes in, that's where the tear is. That's where the pain comes from. All right. You okay? Recovered? How bad is that on a scale of 1 to 10? I couldn't hear him. 10. Is that where you typically get pain? Aren't you glad you had this surgery done instead of fusion? Huh? Yeah. You're going to have 2 little cuts and you're going to be recovered by today. You're going to be back to pretty much normal tomorrow. And your chronic pain, how long have you had back pain for? When did it first start? The first time you ever noticed back pain? Just pick a number. How many years ago? You had a laminectomy in 18? It made you better for a little while? That's the problem, though, is they remove all this bone and ligament from your spine, so the laminectomy weakens your spine. All right, you've had back pain for 15 plus years, right? And that's going to go away today. How are you going to feel about that? Happy. All right. Let's take a look. Shot? Yeah, we're definitely in. How bad is that on a scale of 1 to 10? Give me a number. What's the highest it went? 9 or 10. All right, 10. So that was L5-S1, the bottom disc. Is that where you typically get pain as well? Yeah. All right, so we have concordant pain. You get to go to sleep now. By the way, do you know you have blue blood? You bleed Deuk spine colors. All right, count from 1 to 100 for me out loud so I can hear you. Go ahead, Wayne. Oh, okay, I'll start on this side. All right, folks. So, Diego, let's roll the animation showing our viewers why this patient has pain in his back, chronic back pain from the herniated disc. Show them that video animation so they can learn about what causes the pain.
Okay.
Annular tears.
Scoliosis doesn't matter. Degenerative disc disease doesn't matter.
Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, Dr. Deukmedjian, hopefully you've been able to watch our animation and understand what causes back pain. It's not what people think. And we discovered the cause right here at Deuk Spine Institute, and we've been curing back pain now for 15 years with the laser surgery. We're going to release a video today, which we just filmed, right, Diego? One of my patients that I did a fusion on, L3-4, L4-5, lumbar fusion, 14 years ago. He actually stopped by today to say hi, and he was so happy that he still has no back pain. His back pain was cured with my surgery here at Deuk Spine. And it was a fusion surgery. and he's so happy about it that he wanted to share his story with everyone. So we videoed him, and it turns out he was actually at work when we videoed him, right? He doesn't work here, but he actually runs an aquarium business, and he, for the last 15 years, he basically installs saltwater aquariums, like on that program Tanked, and he takes care of fish, knife, and he maintains saltwater aquariums and stocks them for people. And he's a friend of mine now. He was my patient, but he actually takes care of our saltwater tank here at the office. We have a saltwater fish tank, along with the help of Sonny, who is our IT person. Sonny and Rob, and actually a few of the other staff help as well. So we have a saltwater tank. It's not looking its best lately, but I haven't really put anything in it in a while. We probably need to put some corals in there and maybe some more fish, but we want to keep it a low maintenance system. Anyway, Rob is kind enough to do a video for us, so we'll be releasing that probably this week, so you can see one of my fusion patients. I'm sorry? Am I still doing my coral research? No. I haven't had any time. I've been so focused on the business, and too many other things to do with COVID. I really haven't had time to focus on my research anymore. I've kind of put that on the back burner. All right, so we're advancing the dilator. The dilator is a little metal tube, device. You can see it. It's got a tapered mouth or tapered end. Looks like a pencil on the x-ray. And this is going to go through the tear in the back of the disc. And basically, it's going to spread apart the disc. Shot. So I'm trying to advance it into the disc through the tear. It's going through the tear, and that's the damaged part of the disc we're here to repair. Shot. Shot, yeah. How is he doing? I got it here. So I don't want to trap the guide wire at this point, and it's really tight. Shot? So, look at that. Look at it opening up the disc space. And that's what a dilator does. It opens the disc space. We need the disc space open. Otherwise, we can't fix it. So the dilator goes into the disc space through the tear and herniation. And it literally drags the herniation with it into the disc space where I can actually get it out safely. Some surgeons that do transforaminal surgery or intraforaminal surgery, they like to remove the herniation out of the foramen, but that's dangerous because you got nerves and arteries and veins in there. And inside the disc, you've got nothing except that jelly. And that jelly is biologically inactive. And jelly doesn't care if you're there or not, because when you leave, you just leave the jelly there. Now, he doesn't have much jelly anyway. Shot. So there's not much jelly left. Shot. I think we're about in. Just about. Nice. Thank you. So we're going to remove the dilator and just leave the tube. That we're going to do the rest of the surgery, the endoscopic part of the surgery through the tube. I can tell you, without even looking, that I can tell you most of what we're going to see in here is just basically collapsed disc. Not going to be much nucleus left. It's going to be mostly just end plates, arthritic end plates. But the source of the pain is actually in the back. And as we bring the tube backwards, you'll see that the source of the pain is coming from the back of the disc from a tiny bit of tissue back there called the annular tear. And that annular tear is still there. No matter how collapsed the disc is, the annular tear is still there. I want to get more of these tubes, okay?
Yes, sir. Yes,
Have you ordered them?
I'm working on that, sir.
Yeah.
Yes, sir.
Even if you have to get them from Wolf directly.
That's okay with you?
Yeah,
Okay, great.
yeah. I know they're expensive, but
Yeah, and not everybody use this system. That's why I'm taking some.
yeah. But I'm saying I want exactly this one.
Yeah.
I don't like the other tubes.
No, this one
You know how they have different models?
this one should be no problem at all. Directly into them.
Yeah,
So
yeah. Yeah, let's pick up a couple just so we have them. But look for the other stuff as well.
definitely.
Yeah. All right, so we need a blue towel here. We're going in. This is L3-4, as I've said. And like I told you before, you're not going to see a whole lot of disc material. If you watch a lot of these surgeries with me, you'll see that every disc is a little different, but many of them have very common findings. So this is a completely degenerated disc at a scoliotic level. And again, we are not fixing the scoliosis. We're not stabilizing. We're not screwing. We're not caging. We're not artificial disking. We're not putting anything in this patient that's unnatural. There's a herniation right there. Okay? It's blue because it's degenerated.
You can put that on the table.
So this is a revolutionary surgery you're watching called the Deuk laser disc repair. It's going to replace fusions and artificial discs around the world. The only reason it hasn't is that most surgeons have no clue how to do it, and they don't even know it exists. Okay? It's unfortunate. I need the grabber still. Because if they knew how to do this surgery, that's what they would be doing. The other problem is the surgery doesn't pay very much money to the surgeon. We don't make much from it. So a lot of surgeons aren't motivated to do it because they'd rather do fusion surgery and make more money. On the other hand, that's not good for the patient, though, to do fusion surgery. You know, patients want less invasive procedures so they can get back to a normal life much quicker. And patients deserve to have less invasive surgery. The problem is, if you expect your surgeon to provide it for you, they may not. And the only way your surgeon's going to know how to do this procedure is they come and train at Duke Spine with me because I'm the pioneer of the procedure. Takes about a year of training to learn safely how to do the procedure. There's a piece of herniation. Really not much disc here. So let's get the laser. And the laser is the blue fiber. This is a Homium YAG laser. It's a medical laser, FDA approved. Everything we do is FDA approved. All the equipment we use is FDA approved. This is surgery being done in the United States of America. We don't do surgery unless we don't use things or administer anything to patients unless it's FDA approved. So this entire surgery is done with FDA approved equipment, drugs, supplies. Some people ask that question. All right, let's see if we can't use the grabber again. Let him get a feel for it. Let him grab. Good, perfect. That's good technique. You learn quick and you got a great teacher with Luis. Remember, you're going to want to save those little fragments. We send them off to the lab. Let the pathologist, who's another type of doctor who doesn't like people, usually. Sorry. No, I'm talking sorry to pathologists that I offend. But they like to sit in a room and look under a microscope or look at staining of tissues to figure out what's wrong. Now, I actually have a lot more respect for pathologists than I do radiologists. And there are some radiologists, obviously, that are really good, and they do a fantastic job, but there's a lot that are very lazy, and they do those really bad reads on the MRIs and other studies. They miss things. So we were talking about that last case, how important an actual accurate review of the MRI is to find the source of pain. And most radiologists leave out disc bulges, or they don't value a disc bulge in terms of its ability to cause pain in somebody, which they can, and they do quite often. A disc bulge is a herniation. It's just a small one, but it's still a herniation, and because it's a herniation, it can cause pain. All right, Diego, have you run the animation yet on the surgery?
Yes, I will now.
Let's do that so people can see what we're doing here with the laser
Mm-hmm.
to repair the disc. That's another piece of herniation. Right there.
Here. So that's it. Extend your arm or you keep your face out. Like this, right?
Tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
I'm sorry?
You're
Oh.
back.
We're back to live. All right, hopefully you enjoyed our video animation. It explains what we're doing here with the laser in terms of the annular debridement and getting rid of the herniation itself. By getting rid of the herniation, you're getting rid of the source of the inflammation, or what causes the inflammation. The inflammation is actually not occurring in the herniation, it's occurring in the annular tear. The annular tear is a tear in the annulus fibrosus. The herniation is the herniation of the nucleus pulposus. Herniations themselves don't have a blood supply. Nucleus pulposus is avascular, meaning no blood supply, no nerves. What has nerves is the annulus fibrosus. And it's the annulus fibrosus right here that we're dealing with this very second. This is the main source of pain, the source of back pain, in this patient and every other patient that has a herniated disc causing their back pain. There's some scar tissue right there. So it's tried to heal itself over the years unsuccessfully. That's why it's still painful. A disc herniation that successfully heals itself becomes painless. There's no more inflammation. A disc herniation that unsuccessfully heals itself, which happens in about 10% of people with herniated discs, that thing needs to be fixed with this laser surgery. Or a good fusion if you want to do a good fusion. But most surgeons don't even know how to do a good fusion. Okay? They really don't. I would guesstimate 90% of spine surgeons don't know how to do a proper lumbar fusion to get rid of people's back pain. Fusions are done many different ways. The technique is very important. The devil's in the details. Okay? If you don't do the fusion properly, the patients will still have back pain. Their back pain can even get worse. So, treating back pain is more than just doing a treatment. It's actually about making the right diagnosis, because there's many causes of back pain, and the causes can change over time. They can change over treatment. So you may treat one cause of back pain and another cause pops up its head. And because a lot of people that have back pain, they don't walk properly, they don't stand properly, they have poor posture, they have poor gait, they have poor biomechanics of their spines and bodies. And what that does is it causes aches and pains in joints and muscles that normally wouldn't be painful because of the way you're standing and walking. So it's important. That's a bone spur right there, by the way, that I'm zapping right now, that golden color thing. Small one, but just sitting underneath the nerve. That's why I zapped it. A lot of bone spurs I don't treat because they're not causing any problems. They're just a sign, but they're not a source of the patient's problem. They're just kind of a sign of a problem being there, but they're actually not the cause of itself. So there's no point in treating them if they're not going to make the patient better. I only treat things in here that actually make the patient better. Get rid of their pain. Get rid of their pinched nerve. Otherwise, I don't do anything about it. Like the scoliosis I was talking about earlier. I'm not fixing this patient's scoliosis, but their pain will go away without fixing the scoliosis. Why? Because the scoliosis is not the cause of their pain. And this is something that a lot of surgeons don't understand. They think the scoliosis is causing the pain, but it's not. It's the tear in the back of the disc, the annular tear. It's what I've been saying for many years. Unfortunately, they don't listen because they make too much money doing scoliosis surgery. A surgeon can make somewhere around $15,000 to $20,000 from scoliosis surgery, but you make about $500 for laser surgery. So if you're the surgeon and all you're interested in is money, what are you going to do? You're going to do a fusion scoliosis surgery and make $15,000, or are you going to do the laser surgery and make $500? Right? I know what I would do. I do the laser surgery. That's why I'm sitting here doing laser surgery. But that's because I'm going to do what's right for the patient, not what's best for me financially. But a lot of surgeons today, spine surgeons, they do what's best for them. That's why they're not doing these endoscopic surgeries, because they don't pay well, unfortunately.
Right arm, please.
All right, I'm sucking all the juice out. Scope off. We're done at this disc. We're going to put in some antiseptic and we've never had an infection from the surgery. We don't want one. We used to use bacitracin in our irrigation, but that's become almost impossible to get nowadays. Right, Luis? So we have to use a different antiseptic, and what we use is what NASA created. Everyone knows who NASA is, right? Well, NASA created an antiseptic called betadine, and for the space program, that's good. And we're using the same substance, betadine. It's effective against pretty much all kinds of pathological microbes, whether it's bacteria, fungus, viruses. It's very, very effective. Okay, we're done with the left side. Now I'm going to come over, put pressure here. Come here. Put pressure here. About that much pressure. I'm going to switch over to the patient's right side, and we're going to fix L4-5 and L5-S1. Now, for those of you that showed up late to the party, we already tested these discs earlier, and we found that the L4-5 and L5-S1 discs were causing his pain in his back through the discogram we did. It's called an evocative discogram. Another name for it is a provocative discogram. Go ahead, Jordan, get in there. Let Luis take over. Remember, your back is never sterile, so don't ever bring your back towards his arm, okay? Like, see how this is sterile here? You'll never see me turning my back to the sterile field. I'm going to step away if I have to do something like that. But your back is always considered unsterile. The only sterile area is from here to your nipples, from your belly button to your nipples. That's why you see people just putting their hands right here. Alrighty then. So we're going to do L5-S1. Now we also tested the L3-4 disc. We tested L3-4, L4-5, L5-S1 discs. I thought they were all painful before surgery based on his physical exam and the MRI findings, and we confirmed that all three were causing his pain. All three were 10 out of 10, and all three had tears in the back of the disc called annular tears. Are you ready? We need the fluoro up here. Very good. Thank you. No problem. All right, we're at the L5-S1 shot. So I'm going to put the guide wire in, and now I'm going to take out the needle shot, leaving the guide wire behind. Now, over the guide wire, we have a sharp on the floor. I dropped the needle. Thanks. Actually, I flicked it. Really good. I just thought I'd do some flicking today. Shot. All right, now we're coming down along the guide wire, and it may look barbaric passing this metal tube down. All right, it may look to some of you like, oh my gosh, what's he doing? That's crazy. You have no idea you could poke something important. So number one, I know the anatomical pathway. I know the pathway that goes from the skin to the disc. I know what's there. I know every layer. I know exactly what's there. Number two, I already passed a needle down there, and the needle has told me that I made a nice path that has nothing dangerous along the way. So I feel very confident now, and we're just spreading the tissues. Shot. So at this point, I'm just spreading apart tissues. I'm not cutting them. I'm not damaging them. I'm not destroying them. We're spreading them. Shot. All right, let's see. Shot. All right, good. So we're at L5-S1. We're inside the disc with the dilator. Now take a look here. You see this, Diego? I want the
Yes.
audience to see.
Yes, I see
We're
it.
doing the whole surgery through an incision that's as wide as this tube. That's 7 millimeters, okay? And that's why we're able to do minimally invasive endoscopic surgery, because we have a tiny little tube that we do everything through that little skinny tube. Just because we're using a small incision and a small tube doesn't mean we're not achieving big results. We're going to achieve huge results. The reason why this surgery works is because I'm focusing everything on the one place inside the spine where the pain is coming from. Shot. And that one place is the annular tear and disc herniation. In this case, on the right side at L5-S1. Ready? It's good? Shot. I can see we're right there. Let's pull back the dilator just a little bit. Shot. Sometimes a little bit of tissue gets wedged between the tip of the dilator and the tube. And it kind of tracks both forward. Shot. That looks good. Let's get go ahead and get it out. Get the dilator out. Let's get the fluoro out. You're fine. You can get the fluoro out. If you want to get one more shot, you can. That's fine. Alrighty then. So we're getting ready to do L5-S1 through the right approach. We know he had a pinched nerve over here, so hopefully we've pushed the herniation back through the tear that we just went through, and now I'm going to fish it out of the disc space. Go ahead. You know how to do it, right? Uh-huh. You happy with that? All right, so let's get inside the L5-S1 disc and see what's going on. Now we're going to probably see blue disc material like we always do. That's going to be the degenerated nucleus pulposus. See a little bit of blood clot there. That's the red thing. Now you see it, now you don't. There's some inflammatory tissue. Remember, we're inside the L5-S1 disc. Yeah, I need the pedal. So I'm pulling out a little bit of herniation. This is honestly the most amazing, the most amazing surgery. Come on over here. And hold that, and you're going to wipe my grabber. Okay. Just be careful. Any questions from our audience?
Yes, what is the expected blood loss for this patient?
The expected blood loss with the Deuk laser disc repair is basically 1 milliliter on average, 1. That's, it's really about 10 drops of blood. A milliliter is 20 drops of blood, but we on average lose about 10 drops of blood per surgery. Now the last surgery we did, we lost 5 milliliters, so that's like 5 times what we normally lose. And that's because the patient was taking some herbal blood thinners, some herbal medications. And we told them to stop, but they say they stop, but you never know until you get in the operating room. And then you see when you make the incision, there's a little bit of bleeding. Like the blood looks like thin. It looks, it's really thin. I mean, it's like watery. And you know that there's something still going on with respect to the platelet function, because as soon as you make a cut, it's really the platelet plug that's the first thing that happens, and that slows down the bleeding. And when you don't get a platelet plug, it's called antiplatelet activity. And non-steroidal anti-inflammatories work through antiplatelet activity. They basically prevent the platelets from adhering to each other and making a plug. So long story short, a lot of people who have back pain for a long time and neck pain, they're on anti-inflammatories. Many of them try turmeric and ginkgo biloba. They're on fish oil. Hey, easy. It's fine where it is. It's fine. Yeah. Thank you. Yeah, that's good. So they're on herbals and they're on anti-inflammatories. And remember, a lot of herbals are anti-inflammatory. That's why people take them. They want that anti-inflammatory effect of the herbal medication. So they're on herbals for anti-inflammatory, and that anti-inflammatory effect of the drug also affects platelet binding to form what's called the platelet plug. If you're interested in learning more about that, look up platelet plug on Google, and you'll see what I'm talking about. The platelet plug is the first step in sealing off a damaged blood vessel. And of course, when you use a scalpel, you're cutting through the little capillaries in the skin. So you're going to get a cut, a laceration through the blood vessel. And again, normally people don't bleed at all because they form a platelet plug right away. Great question. So blood loss for this surgery is 1 mil, like 10 drops basically of blood. That's nothing. You do fusion surgery, you're going to lose 500 mils, 500 times more blood loss. And some surgeons, they lose a lot more than that. They lose 1 liter or 2 liters, and they have to transfuse the patient because their technique is so bad. They just make the patient bleed so much by not really paying attention. When I was trained in residency, a couple of my attendings, they just got in there and just started scraping the muscle off the spine with a metal instrument. It was so barbaric, honestly. I've never seen anything. I was just frightened when I saw it, like literally taking what's called a cob retractor and just scraping the paraspinous muscles off the bone and bleeding like you would never seen bleeding. I thought the patient was going to bleed to death. Of course, they typed and crossed and had blood in the room ready to go because they expected to transfuse. All right, so those surgeons are out there. They don't pay attention to blood loss. They don't care about blood loss. But I do, because when you lose blood, it's bad for the patient. It's not just losing blood that's bad, but they lose blood volume. So they become hemodynamically unstable. Their heart has to work harder. If they have coronary artery disease, they may have some ischemia as a result of not enough red blood cells because you've lost so many during the surgery, so they could have a heart attack. If they have a cardiac function that's borderline, they could push them over into, cardiac failure during surgery, and then they have pulmonary edema and pneumonia. There's so many things that can go wrong in spine surgery that you have to really care about every little detail to get it just right. And most surgeons don't care about the details at all. They don't. I'm sorry to break your image of them, but I know them all. They don't. Yeah. Now, are there exceptions to the rule? Absolutely. There are good surgeons out there. They're not all careless, but there's a lot of careless surgeons out there. I've been doing this 26 years. I know it for a fact. And not just in Florida, they're everywhere. I see patients from all over the world. We have patients from all over the world here at Deuk Spine, and I've seen work from surgeons all over the world. I'm going to tell you a crazy story, okay? There was a patient that came to me. She had 2 herniated discs in her neck. And she had a car accident in France. She had 2 herniated discs. For me to fix 2 herniated discs would take an hour surgery. An hour surgery, it's outpatient. Literally 1 day out of your life of surgery, and your life is, now you go back to normal. The neck pain's gone, the arm pain's gone. But where she was treated in Europe, I won't say the country, but where she was treated in Europe for a car accident, for 2 herniated discs in her neck, they put her at bed rest. How long do you think she was in bed rest? A month. Nope. Somebody guessed a month. That's not correct. Yeah, it was a year. They put her in a bed in the hospital for 1 year for 2 herniated discs that I could fix in 1 hour, and the patient's back to normal the next day. So what does that tell you, folks? It tells you that different doctors treat people's diagnosis, no matter how easy it is to fix, like a herniated disc or bulging disc, we fix them in an hour. Some people do crazy, crazy treatments, okay? Because there's a lot of stupid doctors out there. I'm sorry, but it's the truth. And they're in every field, not just spine surgeons. There are stupid anesthesiologists. There are really stupid internists. There's just a lot of, I don't know why, because you think these people had really good grades to get into medical school. And they did. They had to work really hard. I mean, the people I went to med school were pretty smart, but I got to be honest with you, once they got to med school, we had some party animals. I mean, I did all my partying when I was, 15 and 16. I went to Tijuana every night. All right. We partied like animals in high school. But once it came to medical school, it was all serious because, you're basically making a commitment to treat people's diseases. And if you screw up, you're screwing them up. So I took it very serious when I went to med school. That's why I studied all the time and got good grades. But, if you're going to party, you party in high school, maybe a little bit in college, but don't party in med school. That's where you need to be learning. So we had a lot of party animals in med school that ended up, barely passing, barely getting C's, and they really didn't care about studying or doing well. So these are the people now that are doctors. They all became doctors. We're lighting off fireworks in the operating room. I'm just kidding. We're actually just having issues with our pressure bags for the saline. Anyway, so why do I share these stories with you? Because I want you all to know the truth. You cannot trust every doctor out there. You cannot trust everyone that's willing to give you advice. They may have good intentions, but they're going to mislead you. That's why we do these live streams, folks. We literally broadcast our surgeries around the world. They're free. Nobody has to pay for it. and you get to ask questions during the surgery. We even offer free MRI reviews. If you have an MRI, you're not sure what to do, just upload it, you know? Don't direct message me and say, Dr. Deukmedjian, what's wrong? What do I need done? Because you're going to show me 1 or 2 pictures of your MRI. I need to see all the pictures. Okay? I can't tell just based on your MRI. I need to also do an interview. So we need you to fill out the MRI review form. It's all free. It doesn't cost you anything. We use Zoom to do a meeting. And I can meet with you and interview you. You'll see it's really me. And I do it all for free. I don't get paid a dime for doing it. And I have all my staff doing it for me, and I pay them. So I'm actually paying for you to have it for free. Why? Because the truth is you can't diagnose someone's problem just over some an MRI report. That's a big mistake. If you try doing that, I don't recommend it, because the radiologists miss so many things, and if you just go based on an MRI report, you're putting that patient's future and their fate into the hands of one radiologist who could be a really bad radiologist and could have missed the diagnosis. So I don't recommend it. Just do the right thing. Upload your MRI at mri.deukspine.com. Hey, Diego, will you put the link up so people can
Yes.
see it? mri.deukspine.com. Just do the link, fill out your MRI form, upload your images, and let me look at them. We get nothing out of it at all. I spend a lot of money just so that you guys can all have free MRI reviews. So don't think that we're getting anything from it. OMG. I'm like curing back pain and you're struggling with a pressure bag? Right? I'm glad you found the humor in that, because I find it funny too, right? Like, people think their problems are so difficult until they meet somebody who has a really difficult problem. And then they're like, I guess my problem wasn't so bad. Right? There's so many people like that in the world. They have no idea what real problem is. All right. Well, listen. Let me explain something to you. Okay? Are you paying attention? All right. I need you to hear this. What's failing?
It's the edges are ripping. It's not they're popping, it's like they're ripping.
No, what's failing?
So,
The bag.
yeah, it's failing.
Under pressure.
Correct.
Right?
And it's not under too much pressure.
Well, how do you know it's not under too much pressure?
Because it shows you a gauge.
Right. And guess what those pressure gauges are notorious for? Being wrong. Because they're cheap. They're made in China. I am so sorry for the Chinese people watching, but it is true. All right. Well, they're probably from New York, but there's no way they're made in New York. Anyway, they are notorious. Just don't pump it up so much. And yeah, the pressure gauges are wrong. That's what you're dealing with. I deal with it with my fish tanks when I have RODI water, and I'm trying to figure out how much pressure there is in the line. Now we have no flow, so just get us some flow. I think we're done here at this disc. Anyway, that's why you all get to watch these surgeries, so you can actually see everything we do and why we do it. Now this is kind of cool because you can see all the particulate matter just sitting in the water column inside the tube. There's a little bit of fat. See the fat? Yeah. Fat. You can see the little fat cells. Each of those little glistening things is a fat cell. Have a little floating vein in there. A lot of vaporized tissue. I can't keep going because I will overheat the water and overheat the lens and everything else, so I have to wait. Let me know when you're going to get some flow. There's no flow. Now it's starting to come. It looks like a little bit. Yeah, that's better. How much do we spend on those bags anyway? How much?
They're like $70.
70?
And he's the cheapest one.
No. We need to buy a fluid pump. Buy a fluid pump. How could you spend $70 on a freaking bag like that? You guys are killing me. You guys got to tell me when you do stupid things like that.
No, it's the same one. It's the same one that we
I thought these bags were like $5, not 70 freaking dollars. A fluid pump costs a couple $100. I've been too cheap to buy a fluid pump because I wanted to use a pressurized bag. I thought I was saving money. Here you guys are blowing money out of my ass. No more. Look online, find a used fluid pump, and buy the used fluid pump. My God, we can have 5 fluid pumps. We have no flow here. No flow. None. There's none. There's no flow. And it has nothing to, there it is. Come on, guys. You guys got to do the basic stuff right. Like turn on the flow. You guys are pumping the hell out of the bag and you have the flow off. You're wondering why it's not flowing. I'm sorry. I'm not going to protect you from my own criticism for things that you guys shouldn't be doing. So, for those of you wondering, oh my God, it's crisis mode at Duke Spine. No, you should see what it's like in an operating room anywhere around the world. Right? There's yelling and screaming and throwing of instruments. How many instruments have I thrown? Huh? Today, 0. All right, for those of you who've watched me for years, I never throw instruments, okay? I throw my voice, I throw my opinion, but I don't throw instruments. Now, a lot of neurosurgeons are notorious for throwing instruments. But I've never thrown an instrument at anybody. I just don't feel it's appropriate. It's dangerous, obviously. But I can tell you, neurosurgeons throw instruments, okay? Right, Dr. Rafferty? Oh, absolutely. You've seen it, I'm sure. Oh, I would say that's awesome. I wish we could have videoed that. So he was so pissed off that he threw the whole Mayo stand with all the instruments. Honestly, when I work at the hospital, that's how I feel sometimes. I understand, but the point is the surgeon gets frustrated because we feel like people aren't really trying to help, and we're sitting there operating on a human being whose life depends on us to do everything right. You know what I mean? So it gets frustrating, and some of them just react really bad. I can't condone that behavior, but I can understand the feeling and the sentiment. Now, I got to be honest, I haven't felt that way in a long time because, truthfully, I own my own surgery center, so I get to control everything, which I like, and I get to fire people if I want to. So that sense of control is just amazingly therapeutic. By the way, there's the end plate right there, that pink thing. That is going to be the end plate of 5. So having more control over your center is like the best thing that I ever did, you know, in my career. Besides discovering the Deuk laser disc repair. But just being able to control the quality, you know what I mean, of the medications. Because at the hospital, if a surgeon wants a better medication, you've got to get the pharmacist to agree. And the pharmacist, you're like, are you kidding me? You know, pharmacists are not trained better than surgeons. Or doctors to decide what drugs or medications are best for the patient. And I had this issue at at Parrish, one of the hospitals I work at, where as a neurosurgeon, we know what the best treatments are medication-wise. And I was putting a patient on antibiotics for possible meningitis, and the pharmacist was one of those ego people who just, you know, wanted to mess with me. Happens all the time, you know, at the hospitals. And so they said, no, we're not going to approve the use of appropriate antibiotics. We're going to give you a cheap antibiotic that's, in his words, just as good, but of course it wasn't. And I know the antibiotic, it's not as good. And so I had to fight with administration to get my antibiotic that I wanted for my patient approved, which was the right antibiotic. But the problem was you have to fight political battles at the hospital, whereas I don't have to fight those battles in my own surgery center because I know what's best and I just get it, and nobody's going to get in my way. That's the right way to do it. So if you're a surgeon and you're frustrated with your hospital or your clinic and you feel like you can do a better job, you know what's better for the patient, then you need more autonomy, you need more control. You need your own surgery center, honestly. I've had my own surgery center now for 7 years. Thought it was longer, but it's only been 7 years. And because of that, I've been able to do the most complex surgeries, as complicated as the hospital surgeries. And we do them all outpatient, and our patients go home very happy. Speaking of patients going home, just let the patient know we'll be ready to send them home soon, okay? I can't believe $70 a bag, Luis. Oh my God, I'm gonna die. Yeah, make sure we get those refunds. No, we need those machines, the pumps.
Yeah, I just texted Rita to look into that.
Yeah, I feel nauseated. Honestly, I had no idea they were that expensive for those stupid bags. We're getting ripped off. Are those bags from McKesson, or what is it called? They just rip us off. They think we're not paying attention, which we're not, obviously. Come on, guys. You guys should know plastic bags with those cheap little things made in China. Those things probably cost McKesson $2 a bag. And they charge us $70 because nobody's paying attention to the money. Luis, you got to be a little bit more on it. You guys got to pretend that this is your money. Oh, shit, it is. I want to give you bonuses, but I can't give you guys bonuses if we're spending all the money on bags overpaying. That's it. No, we're done. All right, so like I said, live stream so you could see the real deal. That's why we live stream and we hold no punches. This is really what happens, okay? We don't edit these things. We live stream them. Am I proud of my organization? Am I proud that we've been spending so much money on a bag? Hell no. I want to wring necks, but I can't because it's illegal. But also, honestly, I thought those bags were like $5 max. No, they should be. That's the problem with you guys. You guys got to pay attention to our supply chain. If you guys are just buying and buying, you know, we need this, buy it. You guys got to look at the price and go, holy crap, is that really worth it? And if it's not, come talk to me and say, honestly, we're paying like $75 for a bag. I think we should just do something different. I'll sit on the bag. We're gonna put the bag between your legs, okay? And you just squeeze your thighs together. Yeah, you get a workout, you know? I won't charge you for the gym membership. How do you like that? Just, yeah, you get a workout and I don't have to pay for a $75 bag. Come on in. Oh. So we've got 2 discs done, and now you guys know why the cost of healthcare is so high. Little cheap bags with pressure sensors that literally cost a few dollars to make are being sold to us for $70 a bag. It's disgusting. And these companies that provide us these supplies, you know, they know that the staff are not paying attention all the time to the costs, and so they just sneak the costs up on you. And of course the sales rep comes by and they're baby face, sweetie, nice person, and everyone likes them, and they bring donuts once every few months. Meanwhile, they're stealing tens of thousands of dollars from you and overcharging for things, and then they bring a box of donuts and everyone loves them and doesn't question them because they have a baby face. Ugh. If you can't tell, I'm really triggered by this whole thing right now. My blood pressure's going through the roof. All right, I'm glad. Probably not for the same reason. Because you're getting a workout squeezing bags. Okay. I love the comments that come, by the way, during these digressions of surgery. Like, how could the surgeon be talking about money and cost of supplies? Well, because it's a real issue, you know? And we're like a household here. Huh? We're like your household when you go home and you look at your water bill and you're like, oh my gosh, it went up $50. What happened? Well, we have the same issues, you know. This is how we address it. We talk about it, figure it out, work it out, and hopefully fix the problem. Shot. But we have our challenges at the surgery center as well. Whether they're financial challenges or they're staffing challenges or regulatory challenges, Shot. In the end, you know, we have a very complex operation to maintain. This is our last disc. It's L3-4. We're going to put this tube in and get it done. We've already done it 3 times. Diego, any more questions?
No, just a lot of praise, saying that you're doing a good job, and
Oh, that's nice.
they like
Thank you.
hearing from you.
I like to say this is reality TV, you know? Reality TV was a very popular term years ago. You know, I think it still is pretty popular, but this is reality TV. This is not staged. This is 100% real, what you're seeing. And honestly, I would love to extend this reality TV to our clinic and have you come around the clinic with me while I see patients in clinic. The problem is it's a HIPAA violation, and that's a federal law that protects, you know, the identity of people, patients getting care. All the patients you watch these live streams for, they've all given us permission to watch it, to broadcast their surgeries live. We have written permission. It's a consent form. So in case you're wondering, yeah, everybody, by the way, my skirt's falling down. Who wants to get intimate with me? Thank you, Jordan. I love that. Jordan's a great guy. I was just talking about you this morning, Jordan. I don't know if you know, but I was talking about how far you've come along to really be a leader and in our organization. So thank you. So in case you're wondering, I am wearing a skirt, not because I'm sympathizing with men to wear skirts, but because we have to wear lead. I need the scope on. I need the camera on, please. Luis, you should be handling that. It's because as spine surgeons, and really anybody in this room that's close to the fluoro machine, we all need to wear protection from the radiation from the machine. As long as you're wearing lead, a lead skirt, lead gown, then you're protected adequately from radiation. The amount of radiation is small. However, what do we all know about radiation? Huh? Cumulative. Whoa, look at that herniation. Oh, you go. No, let go. How dare you?
Yeah, let me see it real quick.
Look at this. Turn the light on. You can see the size of this herniation.
Yep.
Hit the light on over here. Can you see it?
Yeah, I see it. Leave it right there.
Put it against the white background. Look at that.
Really nice.
That's a biggie. That was a big piece we got out. We fished it out. All right.
High five.
Huh?
You guys do high fives, no?
I couldn't hear you.
Don't you guys do high fives after that?
Oh, no, we're not going to high five on
Okay.
this one.
Okay, cool.
No. We're going to maintain our composure. So what I was saying about radiation, folks, is that the dose of radiation is cumulative. And what that means is that if you get a little bit today, a little bit tomorrow, it all adds up. And What matters is your total dose. Here's another piece of herniation. I can't even get it out. It's too big. Now, this is what I was talking about by the inside-out technique that Dr. Young, Anthony Young, taught me. I've learned all the techniques. There's a huge herniation down there. You see it? Oh man, it's like a big tuna fish, just sitting down there, and we got to fish it out. Oh yeah, getting a lot of this stuff. So Dr. Young taught me the inside-out technique, which is basically where you shove the herniation back into the disc and then retrieve it from inside the disc. A lot of surgeons use that technique, a lot don't. When I say a lot, I mean of endoscopic surgeons. Wow, I can feel it. It just amputated itself. There's a big chunk down there. Right there, you see that? Oh, baby, there's another biggie. You see that biggie? Woo-wee! We're catching big fish today. All right. Oh, another piece. Holy moly, I think we found the mother lode. Right? Yeah, we didn't get this from the other ones. Oh, by the way, this patient, how old is this patient? Roughly. 86 years old. And look at these juicy herniated discs coming out of an 86-year-old. 86, folks. You think you're too old to have spine surgery? Nonsense. If you think you're too old to live, then yeah, you're too old to have spine surgery. There's another big herniation. So this guy's disc was blown right here at L4-5. But basically what I'm saying is, here's an 86-year-old who said, you know what? I want to enjoy my life without pain. And here he is having his back fixed. And good for him. All the more power to him and his spouse for wanting to have a quality of life even at 86. Just because you're 86 doesn't mean you have to keel over and die. You know, if you're going to live, which I hope you all do, get your back fixed. Why not live well? Okay? Live well. That's what we believe in at Deuk Spine, living well. Here you go. And we help our patients. No. You can't. Sticky fingers. Sticky fingers or stinky fingers? I had to get a laugh out of my staff. We are going to be done in 10 minutes, doctor. We have one more surgery to go. That is a mega surgery. 5 levels. Our patient's from Canada, and he's a big boy. How tall is that guy? 6 what? 6'6" or 6'10"? Holy crap, man. Luis, you're I can't even understand you. 6'10". Say 10. Yeah. Say 10. 10. You sound like a squeaky little mouse or something. Like one of the chipmunks, Puerto Rican style. All right. So the next patient is 6 feet 10 inches. So today we're doing some interesting stuff. We did a surgery on an 86-year-old, which is who we're operating on right now. We're doing surgery on a 6'10". This is an almost 7 foot tall gentleman from Canada. And we get a lot of Canadians because they don't have laser surgery where they live. They don't have this kind of stuff done. And they don't want traditional fusions, or they don't want the monkey business that goes on in socialized healthcare systems. And we like our Canadians, so we treat them real well. Canada is one of those countries that can still travel to the United States. So is Mexico, if you couldn't tell. Our borders are open. That was supposed to be funny. As a matter of fact, I've got some British patients who want to come here for laser surgery, and they can't get here right now because the border's closed to British. So we're letting all kinds of people across the border down south, but we won't let British people here. Why? Makes no sense, you know? I'm not a political person. I won't get into it, but it still makes no sense. I know things are changing rapidly, and we should be hopefully allowing those Brits back to the United States soon, because I know Disney World misses them. I know a lot of them bought real estate, you know. There's the tear. They have homes and stuff here in Florida, and they can't come visit them. So it's a shame. Just about done. Any questions for me?
No.
All right. Folks, we are going to wrap this up in about 2 minutes, and I will take questions. I'll answer them for you directly in our broadcasting studio with Diego. And just one more time, Diego, will you run our video animation showing our audience what I am doing with this laser?
Yes, sir.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, Dr. Deukmedjian, we're back, and we're just having fun here doing surgery. As long as that's legal, I think. Still legal, right, to have fun while you do surgery? We're wrapping this up. This gentleman has had 3 discs repaired. This is the last one of the 3, and I am excited for him. His pain will be gone in his back. He had degenerated disc, herniated disc. By the way, he's 86 years old? He's 86 years young. And that's important because a lot of people think they get too old to have their back fixed. Nonsense. If someone tells you you're too old to have your back fixed, come see us at Deuk Spine Institute. We'll fix it for you, okay? I was going to say some more choice words, but you can imagine what I'm saying. There's no such thing as being too old to be out of pain. Safely out of pain, okay? And, you know, doing drugs to get out of pain is not safe, no matter what age you are. It's actually worse when you're older. Drugs are worse, you know, narcotics, opioids, benzodiazepines, muscle relaxers. They tend to be worse for people who are older because they affect their cognition, their thinking. They impair their balance. They impair a lot of things that can cause a really bad side effect. So if you've got pain and you're older, don't put it off. Don't treat it with meds. Go get the Deuk laser disc repair. Come to Deuk Spine. We'll fix it for you. We're all done there. The nerve root is up here in this fat. We're done. It's beautiful. I expect this pain to be gone completely, permanently. All right. We're going to do a little betadine to clean things out. got more of these. Oh, give me 2 then. Right? Give me 2 then. Give me 2 irrigation syringes with 2 needles. With 2 needles, yeah. All right, good. In the future. We're done. Yeah, very good. You know what I mean, Luis?
Yes, sir. Yes, sir. I just sometimes.
And don't buy any more pressure bags.
No. I'm not somebody sure. You know that we business?
No.
Hospital?
What?
Only one, you know what she said? In the hospital, it's only one time use. That's it. So
Huh?
after the case, this is trash.
No. That's crazy.
I do know of a pump that's pressurized. It's by a company called ConMed, and not the 3,000, but you can use 2 1,000 cc bags that water.
Yeah. No, there are pumps that pump endoscopic irrigation from Arthrex, from ConMed, from like a number of manufacturers. I want Luis to find them inexpensive, like secondhand, used, okay? They should be cheap. And a lot cheaper than paying for expensive bags that blow up.
And for arthritis, those type of pumps, you have to get the whole tower.
No, we're going to buy them online from like .med. Okay? We're not going to pay a premium. Okay, everyone, great job. We're going to go ahead and write up your questions if you have them for me. I'll be happy to answer them for you. Type them up. I'll head over there and answer them.